Okay. Good morning, good afternoon and good evening to you all. I can see that people are starting to join us online. Big welcome to you all. The attendees number is steadily growing, so I can see people are still trying to connect. So we'll just give it a little bit longer as people connect and find the link and do their Zoom updates or whatever you need to do with the technology to get it all working. I can see more and more people are joining us, which is fantastic. Hello, everybody. Welcome. We'll be getting started in just a minute as we just wait for all of our attendees to arrive. Okay, let's have a look here. It looks like the popcorn has stopped popping, so to speak. We're not seeing as many people trying to get in. And we are now 1 minute past the starting time. So I think we will get started. So good morning, everybody. Welcome. A big welcome and thank you for coming along today to our webinar hosted by the Australian New Zealand Guidelines International Network Regional Group. My name is Zach Munn and I'm a member of the GIN ANZ Steering Committee, and I'm also the current chair of the Guidelines International Network, and it's my absolute pleasure to welcome you all today to what should be a fantastic webinar. We've lined up some great speakers, some of the national experts on implementation across Australia. So we're really pleased to be able to present to you today this series of presentations and then a panel discussion on guideline implementation across Australia. We actually surveyed ANZ Guideline Network to ask them what would be their most preferred topic for a webinar, and implementation was at the top of the list. So we've put this together for you all today. So I'm expecting a lot of engagement, a lot of questions, and to have a lot of fun as well. So the format for today is a very short introduction from me. Then we'll be hearing from our speakers. They'll all present for about 10 minutes. And then we're going to have a panel discussion. So it should be a lot of fun. Now, this is a Zoom webinar meeting, which means we can't see your faces, but we can see that you're here on the participant list. And we want to hear from you as well. And there's a few different ways that you can interact with us. You can interact via the chat. So please do introduce yourself through the chat. It'd be great to hear who you are and where you're coming from. So please do that. Everyone can see your chat messages, including everyone on the webinar and the panelists as well. If you have any formal questions, and we do encourage you all to submit all of your questions, please use the Q&A functionality, because this will help us keep track of all of the questions and make sure we are answering all the questions as well. If you're having a bit of trouble with that Q&A functionality, you can put your notice or question in the chat as well. We are recording this session. I'm just checking. Yes, we are recording. And we will be putting this video up on the GIN, it says JBI here, but on the GIN YouTube channel following this webinar. And if you have any feedback at all or any questions about ANZ GIN and the work that we do, please do contact us at that email address there. Now, before we get into it today, I would like to acknowledge that here in Adelaide, I'm currently situated at the headquarters of JBI here at the University of Adelaide in North Adelaide. And I'd like to acknowledge that we are meeting on a traditional country of the Kaurna people of the Adelaide Plains and pay respect to elders past, present and emerging, and also acknowledge the traditional owners of the land where you're all joining us from today. We recognise and respect their cultural heritage, beliefs and relationship with the land, and acknowledge that they are of continuing importance to the Kaurna people living today, and acknowledge that this always was and always will be Kaurna land. And I'd also like to extend that respect to other Aboriginal language groups and First Nations and anyone joining us today. And we would love, another way you can interact with us, we would love for you to tweet about this webinar online using Twitter. And we've got a few of the Twitter handles there. You can follow us at GIN_ANZ. And we've also got the Twitter handles of our wonderful presenters today, which you can tweet to as well with all your messages. Okay, well, that's enough from me. So let's get into our illustrious panel today. And first off, we're going to have Dr. Amanda Buttery, speaking to us all. Now, Amanda leads the development of the National Heart Foundation's clinical agenda. Amanda manages the strategic development of evidence-based clinical guidelines, position statements, policies, and their implementation. She has 25 plus years of international healthcare experience across different countries and a PhD in gerontology from King's College London. So a big welcome to you, Amanda, and the stage is yours. So I'm going to stop sharing my screen and you can start sharing yours and we'll get into it.
Thanks very much, Zach. So I'll just share my screen there. How's that? Is that right?
Perfect. We can all see it.
Okay, thanks very much. And thanks very much to Gin ANZ for the opportunity to present today on some guideline implementation that we've been delivering through a national partnership with NPS Medicine Wise and the Heart Foundation on heart failure. So first of all then, just an outline of what I'll speak about over the next 10 minutes is why we're collaborating. Also a little bit about the sort of scope and scale of the project in terms of leveraging assets and expertise, some of the new assets and communications that we've developed through the program, and also the way in which we're sort of integrating evaluation and data along the process, and also just some reflections and take-home messages. So this is a national heart failure collaboration program. The objective is to improve the health outcomes for Australians with heart failure by optimising the quality use of medicines and health technologies in primary care. So how did this collaboration come about? So NPS Medicine Wise approached the Heart Foundation in 2020. And this was following on from our publication of our national guidelines in October 2018. So the Heart Foundation, in collaboration with the Cardiac Society of Australia and New Zealand, published the guidelines on heart failure, which look particularly at both prevention, detection and management of heart failure. And really at this sort of similar time, NPS Medicine Wise received funding from the Department of Health to again address some of the practice gaps in heart failure. So NPS Medicine Wise invited the Heart Foundation to sort of co-design the program with them, with a multidisciplinary expert steering panel with multiple stakeholders. And then as we're getting started on the program, we realised how much alignment there were between our organisations and what we wanted to achieve, which led to a formal collaboration agreement. So just a little bit of reflection on our organisation. So we're both not-for-profit organisations. We both have a strong basis on focus on evidence, and we both offer programs for both health professionals and also direct-to-consumer resources as well. So we thought about some of the benefits of collaborating, such as leveraging our assets from each organisation, making sure that we have consistent messaging from both organisations about the guidelines. We'd have greater access to experts and peer review, knowing that we had our expert guideline panel as a steering group and also all of our subgroups as well, and just improve reach through our networks, and just looking at our organisational reputations and thinking actually if we come together on this, we might have a stronger voice together. So what it involved is NPS Medicine Wise were really involved in most of the program design in terms of the initial stages of getting some of the stakeholders together, some of the formative research with GPs about the focus of the program, getting key opinion leaders together, and also formalising some of the key messages. This had led on to some of the interventions which are theory informed, particularly using Susan Mitchie's work and the theoretical framework. And also building the content for each of the interventions. And then that leads on to the program delivery phase, which is the phase that we're in at the moment. And I'm mainly going to focus this presentation on the program delivery and some of the assets that we've leveraged and developed as part of the program. Just a little bit of background though on some of the formative research. What we found out along the way was that GPs' confidence in diagnosing heart failure maybe wasn't as strong as we would hope, and also there's some suboptimal dosing of medicines, which really was the foundation of the program as well. So we defined the scope and looked at who this program's for. So for people with heart failure, carers, practice nurses and pharmacists and GPs were a primary focus. We then looked at sort of some of the overarching topics that we wanted to cover: patient identification and diagnosis, the classification of the disease, as well as medicines management and some health literacy. So a slightly wordy slide, but I wanted to emphasise how we came about with some of our key messages for the program. Things like a couple of key statistics that we wanted to emphasise in all of our communications regarding heart failure affects around 480,000 Australians and is associated with high rates of hospital admission and mortality. And we also wanted to emphasise that around 50% of people with heart failure are alive at 5 years after diagnosis. And so we wanted to consistently convey that message throughout the program. We know that GPs are ideally placed to diagnose people with heart failure. And again, we wanted to emphasise that as well. We wanted to emphasise that an echocardiogram, so a heart ultrasound, is the single most important investigation for heart failure, and to confirm that diagnosis, as well as depending on that, the results of that test, it actually guides management. We then had some key messages around medicines. I won't go too much into detail of the heart failure medicines for you, but just to say that there's 3 drug classes that we really wanted to make sure that were being prescribed because we know that they make an impact on mortality. And then we also wanted to have some key messaging around the benefits of self-management and making sure that patients are using active action plans as well. So we had some program plans, and we started, of course, with a web page and promotion of some of our materials. Part of the program involves 9,000 visits to health professionals over the sort of 2-year program. We've got sort of medicine-wise article news. We've got an online case study for pharmacists. We've got consumer resources. We've got the MedicineWise app, which again, we're leveraging for this program. We've got media releases going out to both health professionals and consumers, and also taking our messages to conferences as well. And we've also had some webinars for health professionals and evaluation. Just take a quick drink. So just in terms of our existing resources, the Heart Foundation has several. In terms of Living Well with Heart Failure booklets, we've got web pages, a video series as well, and also things like our cardiac rehab service directory that we wanted to make sure we're all part and incorporated into this program. We've also got some new products as part of this program. Things like our chair of our Guideline Expert Steering Committee, John Atherton, did a video for us, which again we put up on our website at the launch of the program, just to emphasise the role of the GPs. We then looked at some of the sort of requests of some of the one-page summaries that the GPs were after, developed these types of resources for them. And again, we had different ways of promoting that, including social media. We then reviewed some of our patient resources. The Heart Foundation has a large array of patient resources, but again, we just wanted to tailor these to the program needs. So again, we summarised these in some single-page fact sheets, again, looking at the 5 questions to ask your GP if you have heart failure. We then looked at some action plans, and again, we had multiple action plans on different topics. We brought these together for one for heart failure. And again, we just made sure that we were highlighting sort of other resources that we know are available, particularly around some of the programs that have been developed for heart failure for Aboriginal and Torres Strait Islander peoples, and also some of the multiple language formats that we have for some of these resources as well, some of which are developed by the Heart Foundation and some of which have been often developed through other collaborative projects. Then NPS MedicineWise set about doing a new pharmacist e-learning module as well. And again, the Heart Foundation, we were reviewing that module in making sure that we were embedding some of the guideline key messages around what we thought that pharmacists needed to know. And again, that was accredited for CPD points as well. We then did a couple of webinars, and again, these were largely driven by through some of the formative research on what GPs were requesting and what health practitioners were requesting. One was around sort of demystifying echocardiography and heart failure diagnosis, and to make sure we suited our GP audiences. We held these often in the evenings, usually around 8 o'clock Eastern Standard Time. And again, when we knew that many of our GP colleagues could attend. Then we also did a more recent webinar looking at multidisciplinary approaches. And again, that was involving a GP, nurse practitioner, a pharmacist, and also a person living with heart failure as well, which was very well received. We sort of had over about 500 attendees to some of these webinars as well, and then we've also got them on demand afterwards and promote them as well. So I think by our attendance, we realised that we're really meeting a need for these types of education sessions. One of the core parts of the program is educational visiting, which is conducted by MPS Medicine-wise educational visitors who are trained in a process called academic detailing or education visiting, which really focuses on behaviour change for GPs. It usually involves a one-to-one session or a small group, and in these COVID times, it's also having some virtual visits as well. But the real focus is on supporting GPs with early diagnosis of heart failure and also initiation of medicines, and really sort of responding to their concerns about what is important to them and looking at how we can influence behaviour change. Some of these resources are particularly specific to the educational visit as well. So these aren't things that are publicly available on our website because they're tailored to the program. One of the feedbacks that came through this process was that the GP software, not all GP software actually makes it easy for GPs to record heart failure. And so MPS Medicine-wise worked with some of the software providers, including Medical Director, to fix that problem essentially in real time so that we had better classification of heart failure on software systems. Just some of the early feedback from the educational visits has been really positive. So 95% of participants in a sort of survey of over 250 GPs at the moment are indicating that their learning needs are being met by the intervention. Really pleased with the educational visiting and the handouts and these types of things. So we've been having some great feedback. What I did want to highlight, though, is just some of the work that has been occurring in some of the remote areas as well. So obviously this is a national program in both urban and remote areas. But there are challenges in things like, and some of the GPs have highlighted this, in obtaining echocardiograms in remote areas, and if a patient's willing to travel to one, and some of these types of practical barriers that the GPs are facing. And again, equally, some of their feedback's been around the fact that often when people go into hospital and then come back out to remote areas, that cardiologists will commence the heart failure medicines often in a hospital setting, and then asking the GPs to titrate these medicines and to do some of that in the community. So what we've done as part of that is to listen to some of that feedback in real time, and therefore looked at which of our products were really meeting the needs of GPs in remote areas, targeting a publication which is Guideline, which is looking at, which has a readership of rural and remote communities, to then highlight some of these assets for these communities. So again, it's not something that we planned right at the beginning of the program, but as we're getting this feedback, we're developing how we then get our messaging out. And I think that's been a real strength of the program. So just some of the reflections. Is that just the alignment between the Heart Foundation and MPS Medicine-wise in terms of our organisational goals for this program. I think the reason we came together so quickly on this one was very obvious to both organisations. The formal collaboration agreement certainly set out the processes by which our governance structures could be organised, and I think that was really important to do that up front, and just make sure that we had some regular meetings around how the processes are going along the way. Having some structured program design and planning is important. Also having the theory-informed interventions, and again, as I mentioned, we drew on the theoretical domains framework. Also just looking at the review processes for all of our products and interventions, and just making sure that everyone was involved and we were bringing in experts for all of those processes. Also recognition of the organisational knowledge of the contextual factors. So both MPS Medicine Wise and the Heart Foundation has our networks and has our feedback through different ways, and we were bringing those contextual factors together in real time and discussing barriers and facilitators during the program, which has been absolutely crucial, I think. Also thinking about practice gaps, and we often talk in implementation about sort of no-do gaps, and I think we have really uncovered in this program that knowledge is an issue in this area for heart failure as well, and so it's not always just a no-do gap. It is about knowledge and skills as well, which we've aligned with the theoretical domains framework. We've also been leveraging our networks, I think, to inform the program and spread the word. So both Heart Foundation and the MPS Medicine Wise has our different strengths, and I think by combining those together, we've ended up with greater impact. And we've also used an iterative and flexible approach really during the duration of the program, which is largely 2 years for the delivery phase, but the evaluation will go on for at least around about 4 years actually. So just in conclusion then, just to say that the collaboration between the organisations is reaching a larger consumer and health professional audience than I think if we try to do this separately. I think we're both organisations are convinced of that, and I hope I've been able to convince you as well. And that the program includes a range of practical tools and resources, and some of which were developed during the program as well to meet the needs and through iterative feedback. Just a little bit about the evaluation as well is just to say that there are medium and long-term outcomes being looked at with this program in terms of changes to GP knowledge, confidence and prescribing behaviour. We're looking at health literacy on heart failure, looking at patient adherence to heart failure medicines, and also hospital readmissions and mortalities. And again, we won't have that sort of data for at least another sort of 18 months to 2 years as well, but just to look at the sort of evaluation timeframes. Just like to acknowledge my colleagues, really, both at the Heart Foundation and MPS Medicine Wise, and all the health professionals and consumers who've been able to help shape this program, and our funders at the Department of Health. So thank you.
Thank you, Amanda. That was a fantastic presentation, and so great to see this partnership and collaboration, and really that all of the practical solutions and tools as you've mentioned and shown us that you've been developing. Really, really interesting. Thank you. We've had a few questions come in from the chat. We're going to limit questions to just one after each presentation, just so we have a lot of time for our interactive panel at the end. But Amanda, there was a question here from Ben, and he's asked, evaluating the package of resources as a whole, or are you looking at engagement with an impact of resources separately?
Yeah, so thanks, Ben, for that question. And I think I've probably presented quite a range of resources, and it is certainly about tailoring it to different audiences, and that's what we've been doing. And I think that's what I was trying to emphasise when I was talking about the rural and remote, looking at, okay, which ones are people using? What's our feedback on them, and then tailoring it to those audiences. So very much so. So we both have health professional and consumers as well. And again, particularly with our webinars, we knew that our webinar, particularly on the diagnosis of heart failure, is particularly relevant to GPs, but then we wanted to bring in a separate webinar on the multidisciplinary team. So again, we really did try and tailor those webinars to making sure that we've got the right audiences, and we were trying to tailor it. So yes, at each part of the program, we're really trying to do that, not trying to bombard people with all of our resources all at once, but trying to drip feed as well a little bit, I think has been really important.
Fantastic. Thank you, Amanda. And there's some lovely comments and feedback coming in the chat as well. So thank you. Thank you for kicking us off today. What a great start. We will now get into our next presenter, and it's my absolute pleasure to welcome Dr. Samantha Chakraborty to the webinar today. So Sam is an implementation scientist and primary care researcher, and has extensive experience in driving evidence-based practice in primary care. Her work is focused on improving clinical care through the development and implementation of high-quality clinical guidelines. And over her career, Sam has worked across policy, academia, and non-government organisations to inform practice and policy changes that improve health outcomes for patients in primary care. And it's an absolute pleasure to have Sam joining us today. Sam, over to you.
Thank you. So let me just share my screen. Is that all good?
All good. We can see it. Yeah.
Fabulous. Thanks, Zach and Danielle and the team for inviting me to give this presentation. It's actually, I was saying to the team, the Gen ANZ webinars have been fantastic. So I'm really thrilled to be part of it. Before I begin, I'd like to acknowledge the traditional owners of the land on which we're meeting. I'm on the beautiful lands of the Wurundjeri people of the Kulin Nation. And I'd like to extend my respect to the elders past and present and any Aboriginal or Torres Strait Islanders who are here today. So why work-related mental health conditions? Did you know that people with work-related mental health conditions such as depression, anxiety, or PTSD that have arisen as a result of work factors experience 3 times longer time away from work than those with other physical conditions? In fact, people with mental health claims are almost always recommended as unfit for work when they first go to their doctor. This is compared with 2/3 of people with musculoskeletal claims. Most alarmingly, in a study that our team undertook a few years ago now, demonstrated that most GPs reported a refusal to treat amongst their colleagues. And many GPs also talked about a reluctance to treat workers with injuries, compensable injuries themselves. So we undertook some interviews with injured workers, employers, GPs, compensation scheme workers, psychiatrists, a whole range of people to understand what these barriers were in practice. And the list that you see on the screen are really what they talked about. They talked about clinical and system complexities, such as lack of visible symptoms that cause diagnostic difficulties. They talked about managing the patient's beliefs and expectations, including about how the illness or the injury arose, and then the recovery expectations. They worried about poor clinical and other outcomes for the patient, such as strained employer-employee relations. They talked about how to deal with conflicting medical opinions. They talked about how to organize good referral and coordinated care for that was patient-centered. They also talked about a lack of time. This is a very time-consuming activity for clinicians. They talked about the financial burden both to patients and GPs. And they alerted us to the fact that there was no guidance internationally on best practice for GPs and how to deal with this. So we decided to develop a guideline. From the very beginning, we wanted to make sure, actually 2 things. From the very beginning, we didn't know if we would have funding for implementation. So we wanted to make sure that we at least developed an implementable guideline. So we did a few things to do that. We chose to use to seek NHMRC approval for our guideline. And we also, from the outset, decided that we were going to seek endorsement from the College of GPs in Australia and the College of Rural and Remote Medicine in Australia. And we did this for 2 reasons. We wanted NHMRC approval because we knew that, one, it would give us the methodological rigor to our guideline to develop a good, credible guideline. And we knew that by seeking endorsement from these colleges, that this was likely to facilitate eventual uptake into practice. We also wanted to align the guideline to the end user needs and to current policy and practice. We did this a number of ways, but primarily in how we defined our clinical questions, and I'll talk about this on the next slide, but also in the membership of our guidelines leadership group, which had a range of people, including compensation scheme representatives, and this was a bit contentious. We then undertook systematic reviews for each of our questions, and we used GRADE to develop our recommendations. And when there was no evidence, then we used expert consensus. We also considered how we described what we put into the text. So when we wrote the guidance, we really wanted to reinforce the messages from existing standards, position statements, and high quality guidelines, so that we didn't conflict with what clinicians were already being told about best practice. We, within our guideline, provided tools and resources for GPs to use to assist them when they provided care, and where we couldn't actually include the resources or the tools within the guideline, we provided links to these resources. And we also provided indicators within the guideline for clinicians to be able to self-assess whether they were working in accordance with the guideline. We also, as part of the NHMRC approval process, released the guideline for public consultation. And that was a whole, I'd love to talk about that a separate time, but we got 100 pages worth of feedback from that. So I wanted to spend a minute just talking about our approach to developing the key clinical questions. So in addition to looking at the data and identifying the evidence practice gaps from the research, we wanted to know what were the dilemmas that the clinicians were facing in practice and the critical issues that they wanted us to address in the guideline. So to do this, we interviewed GPs, psychiatrists, and compensation scheme workers from around the country, and we asked them to reflect on the critical issues that they were facing in practice. We gave them real patient case studies and asked them to reflect on these and describe the clinical dilemmas that they would face when they were dealing with these cases. Essentially, we wanted to identify at what point in the consultation or on the patient journey would a clinician reach for guidance. And we used this to develop our 10 key clinical questions for the guideline. So the clinical guideline for the diagnosis and management of work-related mental health conditions in general practice, the mouthful, was published and it was disseminated widely, but we know that developing, publishing, and disseminating a guideline is not enough, and that we needed to actively implement the guideline in practice. So we arrive at the IMPROVE trial. So IMPROVE stands for Implementing Work-Related Mental Health Guidelines in General Practice. Our primary aim is to implement our guideline. Our secondary aims are to improve the health and return to work outcomes for patients with work-related mental health conditions in our study, to evaluate the cost effectiveness of the intervention, to develop a plan for sustainability and scale. IMPROVE is a hybrid 3 parallel cluster randomized control trial with 86 practices, and we're running it across Australia. Oops, one too far in the opposite direction. There we go. So we thought about how did we choose the intervention? Reflecting on our barriers and our clinical challenges, we decided that these were not necessarily knowledge-based. Our recommendations when we developed them were not groundbreaking. So we knew that these were more about confidence building and other things. And we know that clinician behaviors are often developed over time. They're based on collective reinforcement by peers, previous clinical experiences, and then to a lesser extent, literature guidelines. Excuse me. So we needed to facilitate the development of new collectively reinforced internalized behaviors and beliefs that aligned with the guideline and overcame the concerns and challenges that were described by GPs. So these requirements align well to normalization process theory and the 4 tenets of coherence. Does it make sense? Cognitive participation. Can a GP engage with this? Collective action. Are their peers doing it as well? And reflexive monitoring, thinking about whether a GP could actually implement this in their own practice. We also wanted to reinforce the role of peers and opinion leaders in this intervention. And we also wanted to enable application, practice, and embedding of the new behaviors over time. So our IMPROVE intervention then led to comprise 3 components. And one Amanda's already talked about, educational visits. And we also worked with the National Prescribing Service to develop these. So our educational visits are, excuse me, one-on-one sessions delivered by a GP opinion leader as well as a facilitator from the NPS, in which the GP provides education about the guideline and the recommendations, but also troubleshoots and helps the GP participant to troubleshoot and work through the challenges that they're facing in practice. They then continue this conversation on a virtual community of practice that we've established for IMPROVE and have this conversation with other GPs who are also in the intervention. And through both the educational visits and the community of practice, we provide a range of resources that GPs have asked for or resources that our various policy partners develop. Importantly, the interventions have been co-designed with a variety of stakeholders. So our primary outcome for IMPROVE is adherence to guideline-based care by GPs. and we'll be assessing this using virtual simulated patient consultations. Our secondary outcomes are patient health and work participation, which we'll assess using a variety of validated or well-used surveys. We'll be undertaking a realist evaluation using interviews and website analytics. We'll be undertaking an economic evaluation using MBS and PBS data. So for our international colleagues, that's data about clinical consultations and reasons for consultations and medicines use. And we'll be assessing scalability and sustainability through a stakeholder workshop. We think that the improved trial will result in practice and policy changes. We think it'll result in improvements in GP care through this enhanced confidence that they're going to get from the knowledge, the resources, and the networks that they'll develop. We think these improvements in we'll see improvements in patient health and return to work outcomes as a consequence of improvements in GP care. We think there'll be sustainable change because we've used a co-creation model, and this will hopefully be able to be scaled up. And hopefully this will also have potential to be generalized to addressing other evidence practice gaps in general practice. And we're currently trialing this model in a few other trials. I wanted to briefly mention a few challenges. The first is that there is no panacea. It's hard, long work and relies on a range of expertise from many. There continue to be system issues despite amazing long-term commitment from our partners. We're understanding as we go through the intervention that even though we did many interviews, there are layers and layers of implementation barriers that we keep uncovering. And one that I'm sure many of us are familiar with is funding for implementation and when to think about that. I would like to acknowledge our amazing team. We've had, I've listed here our Guidelines leadership group. We helped develop the guideline and the Improve investigator group and team. Improve is also funded by an NHMRC partnerships grant, and we've had quite a few partners that have worked with us over the years on this. Thank you.
Fantastic. Thank you so much, Sam. What a great study. Really, really interesting. Thank you for sharing that. You mentioned you're using a realist evaluation as part of the evaluation. Could you just explain what you mean by that?
Yeah. Sorry, Zach. Yep. So we're wanting to understand, because the intervention is pragmatic, we want to understand what worked for whom and how. So we'll be doing interviews with GPs in the intervention with their patients to see if the care that they receive changed. And we've also added to that website analytics or social network analysis of the community of practice to assess what actually happened on the community. Did GPs start to talk to each other? Did they start to express their concerns and talk about their challenges? Did they come to any resolutions or did they develop any solutions themselves? And so really understanding how the intervention worked, which I can talk about fidelity a whole nother time. But that's really what the realist evaluation is trying to get to.
That's fantastic. Thank you, Sam. Okay, another great presentation, and we better keep moving on though, so we have some time for the panel discussion. So our last speaker today, and it is my great pleasure to introduce Dr. Elizabeth Lynch. Liz is an NHMRC Early Career Research Fellow and investigating the implementation of the Australian Stroke Clinical Guidelines. She is based in the College of Nursing and Health Sciences at Flinders University. And Liz leads research to implement evidence in inpatient and community-based stroke rehab settings, working closely with people with lived experience of stroke and health professionals to improve how stroke rehabilitation is delivered. And just going off script just quickly, Liz has also authored a fantastic article for anyone who is interested in implementation. which is talks about how there is nothing so practical as a good theory. And this really helps demystify some of the choices when selecting a theory, model or framework for implementation. And it's been incredibly useful in my work. So I just wanted to do a shout out to that work that you've done previously, Liz, because I think everyone might find it useful on the call today. But Liz, over to you.
Thank you very much, Jack. Thank you so much for the opportunity to present, and also for the free plug of my paper. I'd love everyone to read it because it makes me very happy. And I'm just pulling my thing up now. Good to go. So this presentation is very different. It's very focused on quite a small scale compared to the other bigger picture ones we've just had before. But it's talking about how to partner with people with lived experience of stroke, and this implement evidence-based rehabilitation. And so we came to this because in stroke we've got living guidelines. They're extensive, they're very high quality, and when we've done some systematic reviews of patients' experiences of inpatient rehabilitation and their support people, so families and carers and partners, the things that people with stroke and their carers want actually align with strong recommendations in our guidelines. In terms of, we've got strong recommendations that people should be provided information throughout the course of their stroke rehabilitation and recovery, you know, years going on. People should be getting intensity of practice. Therapy should be based on individualised goals, and people should be getting what they need to be set up appropriately for discharge. And not surprisingly, people with stroke and carers need that they want more information. Having more information makes them feel empowered. People with stroke want more practice, and their carers want to be involved in practice. People with stroke want to have therapy that's meaningful to them personally, not just go through the rote of stuff that every other person with a stroke has that actually isn't meaningful to me. And people want to know what's coming up when they leave the hospital system. And in stroke rehab, the context there is probably a little different in terms of people stay for about 4 weeks. The staff tend to have quite close relationships with each patient and their family network. So it's quite an intense relationship part of your rehab. So we hypothesised that that partnerships between people with stroke, their carers, the health professionals, the health service managers, and researchers will lead to the development of feasible and sustainable strategies so that every person with stroke receives interventions recommended in the clinical guidelines, and therein meaning that they'll also get the best chance of an optimal recovery. So to do this, we set up an experience-based co-design study. So I'll just talk you through the process. So we recruited people with stroke and their carers who'd finished their inpatient rehabilitation, and they agreed to participate in video recorded interviews. And so we asked them about their experiences of information provision, intensity of practice, goal setting and discharge planning. After everybody had been interviewed, we then edited that video down to a 30-minute interview and then asked everyone to come back to a workshop. And they all got together and watched this video together, and together came up with a short list of priorities that they wanted to work on to improve their experience, which also aligns with improving the way rehabilitation should be delivered according to guidelines. We interviewed health professionals through a facilitated workshop about those 4 areas and asked them to identify their shortlist, and then we got everyone all together in a room. So the health professionals to date hadn't seen the video, so they watched the video, and then we identified mutual priorities. So the health professionals' priorities actually weren't the same as the people with stroke and their carers, but in every instance, the health professionals are very happy to defer to what the patients and carers had said were as important, because the health professionals are very cognizant of the fact that if people were saying there was a problem, that was what they needed to address, not what the health professionals thought they needed to address if the people experiencing the care didn't see that as a problem. We came up with 3 priorities, then organised 3 work groups, which had people with stroke, carers and health professionals on each work group, and each work group developed action plans. And then we did work over 6 months. where we had monthly meetings held every 6 months. We had a research assistant who was a person on staff who was working part-time, so she worked an extra day to work on this project. And so her role was to support the people with stroke and their carers, to support the staff, action their plans, do a lot of oversight of the overall program. And we then ran through plan, do, study, act cycles to keep working on each of those priority areas. I'll just give you a little demonstration. So this was one of the snippets from the pre-recorded interviews, and everybody on here has given consent for their footage to be shared for education and research purposes. This is one example when we asked people about their experience of how much activity they got on the wards.
To do anything on the weekend, there was nothing there, no one to help you do anything. So what I used to do is to get out of my bed, in my chair, and go around the block. I used to call it go around the block, and that's what I used to do to amuse myself, to try and help myself do something, because there was just nothing there when you actually, for the whole day, and you got there Saturday, Sunday. What do? There's nothing to do there.
And I saw other people who didn't have a son there, and yeah, that worried me for them, because after a stroke, I think that they say the first, I googled a lot of stuff. Those first 6 months are the prime time to regenerate things and get things going. And I just looked at a lot of those people that were sitting there for 4 or 5 hours a day, and on weekends especially, if you've got nothing on, you're just sitting there looking out a window for 5 or 6 hours with no brain stimulation at all.
Yeah, people need to have people to talk to them, to not just teach them, but really talk to them like as people talk to people, because they need it so badly, some of them, they really do.
So that sort of footage was really very motivating for their staff. You know, when they heard it from that sort of perspective, it really made them, you know, they were aware that weekends were a problem. At that point, there was no weekend rehab, but there was a very, very clear, very consistent message that needed actioning. So there were 3 priority areas. One was how information was provided. And so over the course of 6 months, the team developed up a whole lot of information resources, mostly written. And so, you know, just here they've developed up information about who's on your care team. They've developed up a folder that had a whole lot of information about rehab and recovery in it. For activity, they redesigned ward spaces, which was harder than you'd ever think. We had to go through OC health and safety. So the lounge area had been taken over by lifting machines and computers. So they had to go through OC health and safety to find somewhere to store these necessary equipment, and then cleaned it up and made that into an activity area on the ward. And everybody then got home exercise programs to do outside of therapy time. So these are just some quick and dirty examples for you. This was as much a feasibility project as anything, because we hadn't used this sort of methodology before, and we didn't know if it would work. So we did find it was feasible. So we had 90-minute monthly meetings that were held on site at the hospital, and they were very well attended by the people who'd finished their rehab. So on average, we'd have 4+ patients, 1 carer and 8 health professionals. So of the people with stroke and their family members, everyone stayed the course of the project. We didn't have any dropouts. People were organising their therapy around coming into our project team meetings. One chap was toying with reorganising his holiday to come to our monthly meeting, but I did encourage him to go on his holiday. And the staff, we had some staff handovers due to rotations, but they then organised someone from their discipline to fill in. In terms of data collection, we were looking at health-related quality of life, hospital anxiety and depression, patient experience and behaviour mapping, which is where you track how active people are. You know, are they lying? Are they sitting? Are they, whereabouts are they? And we also looked at how much interaction people were getting. Were they talking to people on the phone, or were they just sitting, looking out a window, doing nothing? And we found that we could collect the data very well. So our data collection methods were okay. In terms of whether or not this worked, we did this as a before and after study, you know, collected data before we started and then after 6 months. And it wasn't powered. and we had really different groups. So their average age in the pre-intervention group was 60 compared to 80 in post-intervention. And we had a really different look of patients in terms of much more severe in the pre-intervention group, with only 16% being able to walk independently from their stroke versus over half in the post-intervention group. So in terms of whether or not this intervention worked to address the way information was provided, the way patients were, the patient experience and activity levels, we couldn't compare because we weren't comparing similar patients at all. From the health professionals' perspective, you know, whether or not this is a good sort of strategy, the health professionals loved it. Hearing from a client how things could be better really helped people get motivated to get on board and actually try and change things. Having some really creative ideas with people who had a stroke came up with stuff that the staff would never have considered, which was really, really interesting to kind of watch and listen to. This, in terms of information provision, the staff would come up with 1,000 different ideas, and then the people with stroke and their families would say, don't worry about that, don't worry about that. That's where you need to spend your time and energy, you know, so they really helped fine tune where the people should be focusing. And staff, I love this comment, at this point in time on the ward, there was a big focus on reducing length of stay. There were auditors coming into weekly meetings, and there was a big push to save money. And one staff member was saying this, you know, focusing on the patient experience and making sure that we're delivering good care, making sure we're delivering evidence-based care is why I come to work, you know. So this process had been like a bit of self-care. This is Fawn Cooper. She was one of the members on our, she came to all of our team meetings. She had a stroke and finished her rehab. And I asked her what was, you know, what did she take out of being involved in the research project? I'll play that.
You know, for some people, a stroke is a diminishing thing. I mean, even if it doesn't bother you, it's still, you're diminished in some way. You're not who you were before. And to do this and highlight your experience enriches it. And I sort of thought over the weekend, I thought it's actually ennobled. And I actually looked up ennobled and said giving dignity. And I thought, that's right, it gives dignity to your experience, being able to share it with people who also have an experience of it, but from a totally different way. So yeah, a bit like a beehive with all the little holes, you know, everybody, all the worker bees, all of us giving a little bit to the hive, and then the whole hive, you know, produces the honey. So, you know, you've got that sweetness that comes out of people working together. And you know,
so I just love that idea of everybody with their different ideas coming together and helping to action and making sure we're delivering what we should be delivering. So in terms of working with people with lived experience on implementation projects, it is feasible. It's really enjoyable. The staff loved it. The patients loved it. I loved it. And it brings really creative solutions to long-standing problems with the whole new lens, you know, which I think, I've got a physiotherapy background, and you kind of forget how much bias and just from old habits are ingrained. So having this real new perspective was really exciting to work with. It definitely requires extra resourcing and planning to do it properly, to support the people with stroke to be able to contribute. That's a whole talk in itself. Whether or not it works, jury's out, because ours was not powered. I hope it does. I think there's a lot of promise in it, because in terms of what the staff are available to do, so in terms of changing individual behaviour, I think there's a lot of scope, because it really kicked on to the people's internal motivations to try and do things. Systems level obviously need different strategies. And let's like to acknowledge the co-researchers and everyone who helped in the co-design meetings.
Fantastic. Thank you, Liz. Another fantastic presentation. And really good example of co-design and the importance of co-design in setting priorities and strategies, how it can shed light on issues that might have been overlooked. So really fantastic. Thank you to all of our panel. I can see everyone's videos are on now, and it's time for us to have a bit of a roundtable discussion. And we've got our first question, which I'll invite you to answer first, Liz, but then see if anyone else has any reflections. And this comes in from Kelvin Hill, who is the chair of a GIN ANZ regional group. who compliments you, Liz, on your presentation, firstly. But he would really like to hear about the value and challenges of working with consumers in the planning of implementation. And can it occur at a state or national level, or is it best to focus on a local level due to strong experience and relationships? Would you like to go first, Liz?
I can start. Yeah, thanks, Kelvin. Oh, this is an area that's very close to my heart. I'm learning how to do this as we go, and I think I haven't done it on a state and national level, but I don't think that means we shouldn't. I think we should absolutely try to do that for sure. From this local project, it was so valuable, and the more I do in this space, the more I'm getting out of it. So I completely think we should be doing it for any implementation project. You know, I could get on the bandwagon, but these other guys that have done bigger projects probably can contribute more from me for that side of things.
Well, Amanda, you talked about a national project. Do you have any thoughts?
Yeah, I think that's right. So our project that I spoke about came about through a national collaboration. However, when we actually drill down into what we're doing, we do have some almost, I don't know if I'd call them sub-projects or anything, but we're coming down into the level, particularly around a PHN. So we might have one of the primary health networks that's completely engaged with this program, and therefore we work more closely with them. Equally, we have a couple of areas where they were piloting some of the tools initially as well. So we do have different levels of engagement. And again, often where these things are coming about fortuitously, actually, more than anything else, I would say. So we've got often a champion who's been involved in maybe developing some of our resources, and then that takes a life of its own. So I think we do have a very there is variation across a national program, as you could imagine, and so it's just about both individuals and organisational levels as well.
Fantastic. Thank you, Amanda. Now, Sam, you talked about making a guideline that's implementable, and there's this term that's used nowadays called implementability. Do you mind just explaining what implementability is compared to implementation?
I think that's a funny term because I know I've used it previously, but I think if we're going to say something, I think it needs to be able to be measured. I don't think we know how to do that very well at the moment. So how do we assess implementability? Anyway, I think it is about thinking about implementation right from the beginning, and thinking about how and when and for whom the recommendations are going to be most useful. And there are many ways in which we can do that. There's a bunch of frameworks available. And so for us, it was really just, I think, going back to the NHMRC process, just having a process in which to make sure we tried to cover as much of that as we could. It was also incredibly important to work with our end users to really understand what were the needs for them. We didn't want to be creating a beautiful guideline that didn't actually address their clinical needs. And I think just getting back to Kelvin's question, it was we've engaged with people at local and national levels and a variety of stakeholders. And I think all of those inputs have been really instrumental in understanding what are the actual issues, what can be resolved with a guideline, what needs to be resolved with other changes as well. So keeping that in mind as well.
Fantastic, thanks, Sam. And a really good point that you need to consider implementation right from the beginning. And Amanda, I was wondering, for your group, when and how do you consider implementation throughout the whole process of guideline development?
Yeah, thanks, Zach. And I think probably Liz touched on this as well, is this the funding issue, actually. Sometimes we're funded to do a guideline rather than the implementation, and sometimes that's a separate funding stream, unfortunately. So we do have some system problems that we need to be thinking of. Obviously, even as we're doing that over the last few years, since sort of 2016, we've had some different guidelines coming out at the Heart Foundation. One of the ways that we're trying to address this issue of almost implementability as well, Sam, if I can touch on that, is the what tools are being most frequently used from our guidelines, even just looking at them through our website, for example. So that's the sorts of work that we're looking at the moment, just to say, okay, when we're doing our guidelines, what is it that actually people have? First of all, we've usually, gone through processes of collaborating with end users to ask them what they need, and then actually following that up to say, okay, are they using it? How much are they using it? And one of the issues we've been looking at the moment is our guidelines app. Again, we see that as an implementability type tool, how frequently it's used, whether it's meeting the mark, those types of things. So again, we're thinking of those things as we're going with our guidelines, but we still do have a little bit of a funding gap, I think, in implementation, which is a little bit of a barrier in itself. And so for us, coming together with NPS on a collaborative program that was funded by the Department of Health was instrumental in the heart failure guidelines.
Yeah, definitely. And that funding for implementation, it is so important, isn't it? Thank you, Amanda.
Yeah.
Now, Sam, I think you mentioned in your talk you're using or informed by the normalization process theory. And Amanda, you talked about the theoretical domains framework. And sometimes these theories, models, frameworks can be a bit confusing or off-putting for would-be implementation scientists, I guess. And Liz, I know you've done some work in this field. Do you have any practical advice for listeners today about choosing a model, theory, or framework?
I think try not to just use what you've always used. So if you're doing a project and it's similar to a project before and you used a model and it worked really well, great, that makes really good sense to use that same thing again. But try to just what am I trying to work on? If I'm trying to work on individual behaviour change, then it leans pretty strongly to something like the theoretical domains framework. If you're trying to look at how do teams work together and this thing of, then TDF isn't good, but normalization process theory is really quite nice for teams working together. So keep your eyes open and keep your mind open and but when all else fails, use something at the start of the project all the way through. Don't, even if it's the wrong fit, oh, well, you can do better next time, but make sure you use something at the start all the way through, not retrofit, because that's never good.
Fantastic. Thank you. Really practical advice. We are unfortunately at time, which is a real shame because I would have loved to just keep picking your brains for hours on end, really. But I just want to say a huge thank you to all of our presenters today. Really great presentations and discussions as well. So a huge thank you to you all. Also, a big thank you to Danielle and Kelvin from GIN ANZ for putting this webinar together. And a big thank you to everyone who joined us today. I really appreciated your engagement and taking some time to come along. We will be sending an evaluation for this webinar, so please do fill that out if you can. It really helps us with our planning. And if you have any other feedback or if you want to get involved with GIN ANZ, just a reminder, you can contact us on that email address. But finally, just once again, a huge thank you to you all. Hope you enjoyed the webinar and hopefully see you all at our next one next year. Thanks, everyone. Bye.